This is Dr. Paul Thomlinson from Compass Health Network, and I'm doing a continuing series aimed at inspiring hope and promoting wellness by applying what we know from evidence-based psychology and other sciences to the problems of the day. The goal is to perhaps help all of us get through these times we're living in and living through with grace and humanity. As this is National Suicide Prevention Month, I want to do a couple of installments on that matter, suicide and its prevention. This first episode is a top 10 list, specifically the top 10 research findings driving our new understanding of suicide prevention. I've drawn heavily from and adapted this from the American Foundation for Suicide Prevention, where you can find many other tremendous resources to expand your understanding of suicide and how to stop it. In the next episode, we will talk about major risk factors for suicide that are afoot these days, what impact they seem to be having, and more on what we can do and are doing about it. So let's launch into that top 10 list. Number 1, suicide is related to brain functions that affect decision-making and behavioral control, making it difficult for people to find positive solutions when they're in suicidal mind. The bottom line is, the brains of folks who are fighting suicide are not serving them well. In fact, they are impaired. In particular, for example, research shows that among those fighting suicide, the left frontal area of the brain is less active. That's the area where there's decision-making and executive functioning, as they call it, going on. Decision-making is impaired, and they don't seem to learn from their mistakes, from trial and error, the research shows. They have a hard time seeing disadvantageous and risky approaches. So, again, number 1, the suicidal mind is an impaired brain. Number 2, limiting a person's access to methods of killing themselves dramatically decreases suicide rates in our communities. Making efforts to restrict access to means or ways by which people kill themselves is a very effective prevention strategy. Firearms account for more than all other means combined and are almost always fatal. If we can remove means, firearms, knives, drugs, even for a short time during a short-term crisis, suicide attempters will often substitute less lethal means or postpone their attempt, or not follow through at all. Means restriction saves lives. So the next 3, 4, and 5 I'll take together. Number 3, 90% of people who die by suicide have an underlying and potentially treatable mental health condition. Number 4, depression, bipolar disorder, and substance use are strongly linked to suicidal thinking and behavior. Number 5, specific treatments used by mental health professionals have been proven to help people manage their suicidal ideation and behavior. So, the link between suicide and mental illness is not simple or straightforward, as we've sometimes been led to believe by the media, I think. So let me say a couple of things here. So the vast majority of those with depression or bipolar disorder or schizophrenia do not attempt suicide. They do not. But among those who do, one of the best prevention strategies is obviously to obtain effective treatment for their condition. So in that sense, of course, mental health treatment is an excellent suicide prevention effort. And we now have treatments shown to be effective with suicidal thinking in particular, apart from or as part of mental illness. This is very promising, attacking suicidal thinking as the illness per se, so to speak. We need a lot more mental health professionals who are trained to think this way and trained in these specific approaches. We should also remember substance use, which co-occurs with mental illness very frequently, is a major risk factor, in part because drugs and alcohol lower inhibitions, making it much easier for people to act on their suicidal thoughts. 1/3 of people who killed themselves had alcohol in their systems, according to the CDC. More than 1 in 5 tested positive for opiates, which includes prescription pain medications and heroin. So we should always be concerned about substance use with those that we're worried about with regard to suicidal thinking. It can contribute to suicide in a number of ways, as noted here. Number 6, no one takes their life for a single reason. Life stresses combined with known risk factors such as childhood trauma, substance use, or even chronic physical pain contribute to someone taking their life. It's complicated and multidimensional. And so, as we think about prevention requires many approaches as well. The analogy I like to use is, Just like preventing motor vehicle crash deaths requires multiple approaches. Think about what we do. We have rumble strips on the side of the highway, warning signs, airbags in our cars, seat belts, guardrails on the highway. We have lots of ways of helping prevent those deaths. We need to attack suicide on multiple fronts as well. And by the way, we lost more people to suicide last year than we did to motor vehicle accidents. Think about that parallel. I think we need at least as much effort, energy, and resources devoted to saving lives lost to suicide as we do to car crashes. Seems fair to me. So, community education, means restriction, loving social support, effective mental health treatment, medications, and teaching and learning new problem-solving strategies and skills, for example, are all part of a multi-front war on death by suicide. Number 7, asking someone directly if they're thinking about suicide won't put the idea in their head. And in fact, most will be relieved someone starts the conversation. Just like having a talk with kids about sex doesn't make them have sex. Having a talk with people about mental illness doesn't give them mental illness. Having a talk with someone about suicide won't make them suicidal. It does, however, give them tools to help recognize things that might otherwise confuse or terrify them. It may help them recognize things in themselves or in their friends, and that can save a life. Number 8 of the top 10 list. Certain medications used to treat depression or stabilize mood have been proven to help people reduce suicidal thoughts and behavior. In fact, there's only one FDA-approved medication, clozapine, for reducing suicidal risk in those with schizophrenia. And one major study shows treating mood disorders with antidepressants, antipsychotics, and lithium reduced deaths by suicide. Now, lithium seems to reduce suicide among those with bipolar disorder, but those studies are controversial for a number of reasons we don't have time to get into here. But when thinking about medication and suicide, again, it's not simple. Medical professionals' ethical code is undergirded by the principle of first, do no harm. When antidepressants are started or when doses are increased, a few patients, and especially children, adolescents, young adults, may experience increased anxiety, agitation, restlessness, irritability, or anger, which can lead to suicidal thoughts or even attempts. Paradoxically, this is troubling. So in short, these risks should be discussed with patients and families by the prescriber before treatment begins, and of course should be monitored closely once treatment is underway. Number 9, if someone can get through the intense and short moment of active suicidal crisis, chances are they won't die by suicide. This is why that once suicidal, always suicidal, or if they really want to kill themselves, no one can stop them those myths are so dangerous. They may make us complacent or fatalistic about helping when it's needed most. Remember, rumble strips, warning signs, airbags, seatbelts, and guardrails. They are, and we must be, on duty all the time to help folks get through a short-term crisis and save lives. And on a related, and I think hopeful note, the final research finding is number 10. Most people who survive a suicide attempt, that is 85 to 95%, go on to engage in life. An analysis of 90 studies by Owens back in 2002 of people who made suicide attempts showed about 7% eventually died by suicide, unfortunately. About 23% reattempted, but not fatally. And 70% had no further attempts. But it's complicated. Even though a history of suicide attempts is one of the strongest risk factors for death by suicide, most people who die by suicide do not have a previous attempt. Only between 25 and 40%. Which is why we have to take seriously every expression of suicidal thinking and intent, intervening whenever we see, hear, or suspect it. We may not get another chance. And hey, if you're looking for a good handle on what you or anyone you know can do to prevent suicide, let me recommend a resource that Compass Health Network shares as part of its call to action. The National Council for Suicide Prevention has developed a campaign called Take 5 to Save Lives. It takes 5 minutes to complete their 5 action items, which is 1, learn the signs, 2, do your part, 3, practice self-care, 4, reach out, and 5, spread the word. It's a great tool for anyone. So go out to www.take5tosavelives.org. That's take the number 5 to savelives.org. Check it out, please. And please come back for the next episode where we'll talk more about the risk factors afoot in the COVID-19 era, trends we're seeing, and what's being done to fight a potential pandemic within a pandemic. I'll have one of my favorite people and one of Compass Health Network's suicide prevention champions, Lauren Moyer, as my guest. You don't want to miss that.